Hi, Diagnosis and Management to Dr. Kim Paxton. This week we're going over the disease management of chronic kidney disease, which is actually a pretty complex medical problem. I'm going to put myself into a slide share form and get going on our presentation. All right. So this particular lecture was actually put together by Dr. Nicole McCormick, who works over in the University of Colorado hospital system in one of the outpatient clinics related to the kidney and pancreas transplant program. Nicole is absolutely phenomenal, and if you ever get the opportunity to work with her as a preceptor, I would really encourage you to take on that opportunity, because she will provide you with a wealth of information to really help you get a real nice base of this for your primary care practices. So first of all, just a quick review. What do the kidneys do? So what is their real function? Well, as you guys can remember from your pathophysiology class, they've got three main functions. So they're going to help maintain our body composition, and most of that has to do with our fluids. So it's our volume, it's our electrolytes, and it's the acidity. It also helps us to excrete our waste products, and it helps us to metabolize and to excrete drugs that our body ingests. It also helps with the production and secretion of enzymes and hormones. Most specifically is the renin and the D25 dihydroxyvitamin D3 that we need for our matrix of bone development. So just giving you a quick reminder of what the kidney structure actually is, and of what your actual nephron structure is, and how the glomerulus works, and how we actually have that exchange that occurs between the glomerulus and the actual blood system. So you have this slide. You also have had this in your patho books. So here's a question. Of all the electrolyte disorders that are commonly found in a person with chronic kidney disorder, late stage, all of them are present except for which one? So which one of these would not be present in somebody with chronic end-stage kidney disease? So take a second. Which one do you think it is?
Don't they get high phosphorus?
They could. So which one is the except? So does a person with chronic kidney disease, would you expect to see them have some hypernatremia? Would you expect them to possibly have some hypercalcemia? Would you expect to see them have hyperkalemia?
Yeah.
Would you expect?
Definitely expect hyperkalemia.
Yeah, absolutely hyperkalemia. I'd agree 100% on that one. What about that hypophosphatemia?
Yeah, because it's the other way.
Yes, exactly. If your kidneys can't excrete, you're not going to have hypo states. You're going to have hyper states. Does that make sense?
Mm-hmm.
So no matter what, you would have, this is the correct answer, it's zero except. So on our exam that's coming up this week, if you see questions like this, and we're dealing with chronic kidney disease, you're not going to see hypo states. You're going to see hyper states. Okay? Next one. All right. So now let's go a little bit further into this awesome kidney function in that glomerulus. So just going back into what is GFR? Now we use GFR a lot because we want to know, just coming off of our CMP, how this person is doing on a more global basis. So with the GFR, it's going to tell me how well that glomerulus is able to work. All right, so that's its main function. So when we get changes in the GFR, that change is going to be in its permeability or in its net ultrafiltration. When our GFRs go down, or we get a lower GFR under 60, it's telling us that one of these two things is not working properly. So either there's been a decrease in the area of permeability, or there's been a decrease in the glomerulus' ability to do its ultrafiltration, something's happened here. Now, what does this mean if you look at it at a more global level? It means that the kidney is not going to be able to do its excretionary functions properly. Okay? So that's what it really means. So the GFR, though, you guys, it's dependent upon what the person's body size is, what the age of the person is, the physiological state or the health of that human's body. It also has a relationship to protein. So high protein diets and high salt intake diets can actually increase a GFR. And age is the one thing that we know causes GFR to decrease. So as a person chronologically increases in age, it is expected to see changes in the GFR and it for to become less effective. So here's a cool little filtration equation down at the bottom. I do not expect you to have this memorized, so don't do that, okay? But this total picture here helps explain to you how this actually happens and where it all happens at. So when we look at, okay, I've got a person in my primary care clinic and I need to measure their kidney function. All right, so we're going to use our GFR as one of our markers. And what that is telling me is the endogenous filtration, what's happening with it. And it's also providing me with information from that CMP of what their BUN and what their creatinine is. When we look at a person's kidney function, we look at the GFR, and then we look at the creatinine, and then we look at the BUN. Nicole was telling me that the cysteine C is something that they're looking at actually being better to determine kidney function than the BUN and creatinine, and that we may be seeing the cysteine C actually coming forward in the future as a marker. Right now, you may see it occasionally if you happen to be in the nephrology clinic, but we're not using it at this time as the marker for how do you determine kidney function. Kidney function is determined using GFR, looking at BUN, and looking at creatinine. So when you look at creatinine, we have this thing called creatinine clearance. So a 24-hour urine collection is your best determinant of understanding how well creatinine is being cleared out of the human body. All right? We use the creatinine to actually estimate GFR. And this cool little company, or this cool little grouping of people here called the Chronic Disease Epidemiology Collaboration. It's a group of individuals who work with chronic diseases related to the kidney on a regular basis. They have this thing called the CKD epi is a preferred equation. I don't expect you to know this. It's more like an FYI. And when they utilize this equation, they have determined that they can get a better determinant of kidney function than just looking at like a 24-hour urine or just looking at a BUN and creatinine altogether. If you are going to be working in nephrology, you may see this particular equation and then the readings that come out of it, but you're not going to see it otherwise. Most of the clinics are not doing that. They're saying it's just more precise, and that it actually helps to really define out, are they really in stage 4 renal failure, or are they more in stage 3? In the primary care setting, when we have patients that actually have a renal dysfunction and it becomes more severe, or their GFR is becoming like in the 20s or maybe the upper teens, we're going to get that person in with a nephrologist. Their care delivery and what's happening with the kidneys is going to require that. In primary care, which we're going to go over as we get into these slides a little bit more, we're able to handle usually stage 1 and stage 2, but when it starts heading into stage 3 and stage 4, we usually will transfer them over into a nephrology care. We'll talk about that more in just a little bit. So we also have another test. We have our albuminuria, or our proteinuria. And when you're looking at proteinuria, which is actually the albumin, when you look at proteinuria, what we're looking for as practitioners when we order this test is there damage to the glomerulus? Remember that albumin, or the protein molecule, is a very, very large molecule, and it is not able to easily pass through the nephron. So if we're having a lot of protein showing in the urine, that's telling us that the nephron, which is, there's several of them involved in the glomerulus, has been injured. So that's what it's telling us. The higher your number related to proteinuria, the greater is the estimated injury that's occurring to the glomeruli. So your normal levels are about 20 milligrams in a 24-hour period. Adult normal urine protein is less than 100 milligrams in 24 hours. And excretion of protein can increase with fever, infection, and with damage to the glomerulus. We use proteinuria to help us understand what the potential prognosis is for this individual for further development of kidney injury. When we see proteinuria, we have, and especially if it's a small amount of protein actually being excreted, but it's indicative that the person is experiencing some type of an injury to the glomerulus, we have opportunities to begin working to preserve what is left of this person's kidney function and try to keep the patient from going into a more advanced stage of renal disease. So let's say it's me, and you do my urine and you run a proteinuria on me, and you find out that I'm actually showing about 250 milligrams, so I have microalbuminuria. Now is your opportunity to get me on an ACE or an ARB, if I can take it, to try to preserve kidney function. And we'll talk more about types of treatments in just a little bit. Nephrotic range proteinuria is greater than 3 grams. These are individuals who have significant disease. And if we see this person has more than 3 grams, or like 2.9 grams of protein in the urine, we know that they're having significant renal glomerular damage. We need to get them over to nephrology and have them seen in nephrology. So there's a couple ways for us to do this. We can go ahead and order a urinalysis on our patient. We can do a dipstick. Now, you guys have all done dipsticks, and they're not very sensitive though. And depending upon how long you leave it in the urine, if you don't follow the instructions on the keto stick, not the keto stick, but the Eurostick package, you could possibly get higher coloring than you actually should be getting. But it can give me an understanding that, yes, I have protein. It cannot detect, though, the microalbuminuria, which is your 30 to 300 milligrams. It can't do that. Your gold standard for finding proteinuria is actually doing a 24-hour urine, and you're looking for how much protein is in that urine and how much creatinine is in that urine. You can do a spot urine, and that spot urine you can do with a urinalysis, and you're looking for what is the ratio between the protein and the albumin. So normal for your protein, you want less than 300, and for your albumin creatinine ratio, you want it under 30. So if you have numbers, let's say you did mine, and I came in at 125 for my PCR, and I came in at 20 for my ACR, I'm normal. I'm okay. I don't have any problems going on. I'm good right now. We typically will see this type of a assessment done on people who are type 2 diabetics. When they come in with the complaint that they see when they pee that there's lots of bubbles, or it's like kind of foamy in the toilet. That foaminess is what a person sees when they have protein that's coming through in their urine. And we'll talk more about that. Okay, here's a question. Creatinine is best described as a substance produced by the kidney, a product related to skeletal muscle metabolism, it's produced by the liver and filtered by the kidney, or it's a byproduct of protein metabolism. Which one do you think it is?
B.
I think it's B also. Yeah.
You are correct. You guys are awesome. It is skeletal muscle metabolism. So the creatinine that we see is a byproduct of the normal skeletal muscle contractions or the metabolism that occurs to elicit a contraction. So we're supposed to have a creatinine level because we have skeletal muscle that's doing its thing every single day. But if our creatinine begins to rise, it's telling us that A, something may be happening with my skeletal muscle, or B, something is happening with my kidney and it's not able to do the processing of the creatinine appropriately and it's beginning to rise. Does that make sense? Now remember that BUN is your breakdown of protein from your dietary sources and other sources of intake. All right, creatinine clearance, usually A, approximates glomerular filtration rate, does not change as part of aging, is greater in women compared to men, or it increases with hypotension. Which one can you take off right away because you know it's absolutely wrong?
It's definitely not B.
It is definitely not D. You are absolutely correct. Hypotension will not cause creatinine clearance to do anything. So what answer do you think this one is, guys?
The A?
It is, you are correct. Creatinine clearance usually approximates how well that glomerulus is able to filtrate. And remember what I just said just a second ago. If your creatinine begins to rise, either something's happening skeletal muscle-wise or something's happening with the kidneys functioning. What is the kidney functioning? How are we able to determine that? GFR, creatinine, and BUN. So A is your most correct answer. Good job, guys.
Is it generally equal in men and women, or is it actually greater in men because they have more skeletal muscle usually?
That is really strong critical thinking, and what you just said is correct. Theirs is usually just a little bit higher than women's because of their muscle mass.
Okay.
That is correct. That is really strong critical thinking. Good job. Okay, one more question, you guys. Albuminuria testing should be avoided in patients who have A, engaged in low-level exercise within the previous 48 hours, taken non-steroidal anti-inflammatories in 24 hours, have a urinary tract infection, or are menstruating. Now, this is more than one answer, so there's two answers to this one.
Not A.
Maybe
It's not A.
Yeah, not A.
I heard C. You are correct. It is C. And
D.
yes,
Menstruation, yeah.
correct.
There's protein.
That is two.
There's
Yeah.
protein in the uterine lining.
Yes, and don't forget that on those red cells, those are protein component too. So you are correct. So C and D would be your correct answers. Good job, guys. There you go. All right, cool picture. So chronic kidney disease, it's something that evolves and it can happen over time, like with a type 2 diabetic. And an individual typically can have chronic kidney disease occur after they've had some kind of an acute assault against the kidney that causes necrosis to the glomerulus, for instance. So that can definitely happen. Nicole found this really cool picture for you guys, and I thought it was really, really nice of her to provide that to give us a visual. We start off with everybody being normal, and we screen for chronic kidney disorders and risk factors. We're going to talk about risk factors, but the screening is your CMP. So when people come in for their yearly physicals, we typically will do a CMP. It gives us a lot of information. We get a creatinine, we get a BUN, and we get a GFR. If that GFR comes in low, now we've got a person that moves to the next level. They're at increased risk, okay? We actually may have damage. And we know that if the GFR is a little bit off, we have to look at, okay, how old is this person? Do they have any medical problems? Are they taking drugs that could affect this? And we're going to talk a little bit about drugs because that's a big thing here. So this kind of gives you a way to put together a clinical reasoning for how you think through normal to the development of CKD. That was a really nice slide. So what is chronic kidney disease? What is it, and how do we actually determine that, yep, this person has it, and we put the label on them as a diagnosis? Your GFR has to be under 60 for at least 3 months. And there it is right there. GFR under 60. So let's say you did mine, and a year ago, I was 59. And 6 months later, you checked me again, and I was 59. And you checked me a week ago, and I come back being 57. Would you say that I have CKD occurring?
Yes.
Yep. Is
Yes.
59 under 60? Yes.
Yes.
It's underneath it. So you can't say, well, it's just one under. It's under 60. Something's going on. We look at other things too. So we look at that GFR. It's the first thing we're going to be looking at. But there's some other markers that we look at also. So we can look at that albumin creatinine ratio. We can look at the electrolytes. And what would you expect if I have chronic kidney disease occurring? Would you expect to see a change in my potassium?
Yeah.
Could be acute.
Hyperkalemia.
Yep.
Yep.
So you could see that potassium going towards the high end. And as people evolve in chronic kidney disease, they could be sitting at that normal potassium level, like let's say they're 4. They're right in the middle. They're 4. And 6 months later, they're 4.5. And 6 months later, they're 4.9.
Mm-hmm.
And now 2 years after you first saw that potassium creeping up on the normal, now it's 5.1.
Yep.
It can be a slow process for some people, but an astute nurse practitioner has the ability to go back and pull up and look at a time frame over the last year if the person has had more than one lab draw done for this particular marker, and look at how are they graphing out? How has their potassium been looking over a period of time? And sometimes you can actually see that patterning of it increasing, and you can also see the patterning of the GFR going down. So that's one of the things that EPIC allows us to do. Cerner allows it to, so does McKesson. We're able to actually see time frames related to specific processes. We can have some pathological abnormalities occurring to the kidney. So let's say I had a kidney stone that obstructed and I developed hydronephrosis, and I'm not able to excrete the urine out of my kidney. Well, that could cause kidney damage. Hypertension is your biggest hurter of the kidney, and right after that is going to come diabetes, type 2 and uncontrolled type 1s. This slide talks about the prognosis of progressing into a chronic kidney disease, and it takes you through the entire process. So it talks about what is occurring, the hemodynamics of the process. It talks about the injury and what happens to the kidney, and then it talks about the non-hemodynamic status that can affect the kidney and cause the kidney to start developing malfunctioning. So when we look over at the hemodynamic, we see the words vasoconstriction, sodium retention, glomerular hypertension, and you see all of that above the hyperplasia and the permeability changes that occur. All of that's about pressure. So vasoconstriction is about the pressure. It's about the intimal lining of the renal artery. Sodium retention increases the vascular bed, and the circulating vascular inflammation, and that increases pressure. So the hemodynamic component is really related to the pressures and to the dynamics of structure that can lead to increased pressures in the kidney. So I want you to think of the renal artery and renal artery stenosis. So narrowing or a constriction of that renal artery. That's going to change what happens inside the kidney. So this individual is going to start having higher pressures in the kidney, which will begin to affect the RAS system. And you're going to start seeing them having hypertension that you can tangibly see through a blood pressure. So injury to the actual kidney itself, there's a lot of different things that can happen. A person can actually have trauma to the kidney, which can decrease blood flow. Hypotension to the kidney can cause death to the glomerular structure. So I want you to think of a trauma patient, or I want you to think of a septic patient. Let's go with the sepsis patient. So you've got a septic patient and they're crashing and burning on you. And they've got a blood pressure that is 71/20. They've got a heart rate of 126. What drugs are we going to give them to try to bring the pressure up? What have we seen people get to bring their blood pressures up? Could we do a fluid bolus and try to bring their pressure up? We could do a fluid bolus. What kind of fluid would you use? So you got a couple choices. Would you use lactated ringers? Would you use D545? Or would you use normal saline, 0.9?
I'm thinking saline.
Yes.
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 But could you do a hypo? Oh, sorry.
Sorry, Joy.
I was talking over you. Go ahead.
Oh, I'm done. That's all I was saying.
Oh, could you also do like a hypotensive normal saline? So like 0.45?
I would not do 0.45
Okay.
because 0.45 is actually going to change the osmolarity, and it's going to
you would
pull
just do normal
fluids,
saline.
and you don't want to do that. What you want to do is fill a space. So normal saline, 0.9 normal saline, is isotonic. And so you're just going to be filling spaces, and you're going to increase the circulating volume, which is going to increase tension on the vascular system, which is going to raise the pressure. Okay? If we start using like lactated ringers has sodium in it, has phosphate in it, it has potassium in it, and it could potentially cause a shift in electrolyte, which you don't want. Because when you're hypotensive, all you want to do is try to get that person's blood pressure up. You don't want to be trying to push fluid in and out of cells. You just want to get the vascular space to increase its volume, which increases the tension against the vascular structures, against the arterial structure. That's all you really want to do. So you could do that. The two drugs that I'm thinking of that we typically see people get in sepsis are dopamine.
Yep.
And norepi. Okay, so Levophed. And with that Levophed, with dopamine, we can give dopamine, but we can give it to what's called a renal dose up to 20. And when you start going above 20, you no longer are helping the renal artery to dilate. You're actually causing constriction of the renal artery, which is now reducing blood flow to the kidney and causing change to the glomerulus. Levophed, and do I have any ICU people out there?
Mm-mm.
Okay, nope. Levophed, we call them leave them dead. With Levophed, you will cause massive vasoconstriction all over the body to try to bring as much blood back as possible to the heart and to the brain and to the lungs. You will sacrifice the kidneys. You will sacrifice your bowel to preserve your heart, pulmonary, and brain for perfusion. That's not a good drug, but sometimes it's all we have that we're able to use. Okay. I'm not going to test you on that, so please don't think that that's what's going to happen. That's just molecular information. Then the non-hemodynamic inflammation and fibrosis can occur, and it explains the process. Don't forget that drugs can cause inflammation. All right. So let's take a look at this non-hemodynamic for just a second. What can you guys think of a drug over the counter that people take on a fairly regular basis that could disrupt kidney function and potentially cause an issue in the non-hemodynamic area? What drug over the counter could potentially come into play here?
Like
Maybe
NSAIDs?
Yes.
ibuprofen.
Yes. Ibuprofen and naproxen. Both of these have a COX-1 inhibition that occurs. It's a COX-1 and COX-2. Naproxen has no ability to work on fevers, so it doesn't have any of the pyrogenic effects, but Advil does. But both of them work on COX-1 and COX-2. So in the COX-1, the cyclooxygenase, that enzyme, is part of what is necessary to maintain normal kidney function. And when you start inhibiting cyclooxygenase on a fairly constant basis, you can begin to affect kidney function, which would be a non-hemodynamic change. We also have the inhibition that is occurring for prostaglandins. And your kidney also does need prostaglandins to achieve proper function. So people who use long-term naproxen or ibuprofen or use more than what's prescribed could potentially develop renal failure or chronic kidney disease because of those drugs, just as an FYI. And that's something, as a nurse practitioner, when you start seeing somebody who looks really healthy and you're seeing changes in their GFR, I'd be asking, how much ibuprofen or naproxen have you used in the last couple months, or are you using it?
Dr. Paxton, can I ask a question about that?
Oh, sure.
So I know that those NSAIDs that you just talked about were COX-1 and COX-2. Something like meloxicam, which is just COX-2 only, would that affect the kidney like as significantly as?
No. That is a really good question, Tara. That is an excellent question. And actually, we have the meloxicam that we can use, or it's called Mobic. The other one would be our Celebrex to use, which is all COX-2. What they say about meloxicam is that it predominantly works on the inflammation component and the prostaglandin component of the cyclooxygenase 2. That's where it lives the majority. There is a little itty bitty little bit that potentially sloughs over into the COX-1. Not a lot, but just a little. So people who have had a change in their GFR because of taking NSAIDs, these individuals can be taken off that NSAID. You need to leave them off that NSAID for at least a month. Use alternative ways of working with their discomfort, and I would highly recommend the use of the topical arnica. The arnica gel that's out there works phenomenally well. Give them a month off, recheck their GFRs. If they're rising and coming up, or they're back into the normal range, then you can start the meloxicam. And you should be fine. They're going to need closer monitoring, so I would say do a CMP or do a BUN and creat or just a GFR at least every 6 months, so you know how this person is going to respond to that drug, and that you are staying on top of it so they don't potentially go back into a kidney state that would not be normal. Make sense?
Yeah, thank you. Do you think that would be something that we could get covered by their insurance if we kind of have like if they have any issues with their kidneys, do you think that's a way that we could get it covered by their insurance? Okay.
Most insurance companies will cover the meloxicam. You don't have to typically go through a referral process. But if you're going to go to the Celebrex, you have to do pre-authorization and you have to prove why. So if your person has stage 1 kidney failure or kidney insufficiency occurring, that would be a reason to take them off the NSAID and why Celebrex would be the better drug for them. And then you'd have to identify what is the need. They have osteoarthritis. And I have not seen an insurance company deny pre-authorization based upon those parameters. That is a good question to ask.
Thank you.
You're welcome. So let's look at, so what are the risk factors, you guys? So who are the people that we get in primary care that we really need to kind of be looking at them a little bit more carefully and maybe even monitor them more carefully? Anybody with diabetes, type 1 or type 2. Your type 1s automatically fall into that category of closer monitoring for a lot of different things. Remember that diabetes, that increased sugar, produces an inflammatory effect. It produces it inside the intimal lining of our arterial system, but it also causes an inflammatory process inside that glomerulus. Okay? Hypertension, we've got that one. But here's a new one for you, you guys. Autoimmune disorders like lupus or sarcoidosis. These immune disease processes can produce an inflammatory process inside that kidney. So that's why people with autoimmune, including rheumatoid arthritis, need to have closer monitoring of their kidney function. And when I say closer monitoring, you get your baseline. If it's normal, repeat in 6 months. Kidney stones. These little gems, we all know they're very, very painful. We learned that last week. But these little fellas can actually cause obstruction, which some of you had talked about with respect to the PBL we're doing this week. And you're right, this could have been present because kidney stones present back pain and it's actually CVA tenderness, but it's in the back. People don't know what CVA is. We do, but they don't. But these kidney stones can actually obstruct, and they usually form inside the kidney, and they can actually obstruct and cause the hydronephrosis, and left unchecked can actually cause necrotic syndrome to occur within the kidney. Well, if you get necrotic syndrome, you've got death occurring of a nephron. And putting all multiple nephrons dying, you can get into acute kidney disease very, very quickly, which then turns into chronic kidney disease. So what characteristics of people do I have to take into account? Age is your big one. Age is your biggie, okay? Anybody who has had a reduced nephron mass. So the example here is people who have one kidney, somebody who has had a transplant, okay? And somebody who has donated their kidney. They just now have one kidney. When we think of a solitary kidney, we typically think of somebody who was genetically born with just one kidney. But right now we have a lot of people who are being donors for other individuals, and they become that solitary kidney person too. So when you do that, their surgical review, finding out if they donated a kidney to anybody would be something you'd want to include. Here are your risk factors, and just take a look at the list. Some of these you've already picked up on. Obesity. Obesity's link is that obesity isn't just usually obesity. It's usually a triad of problems. It usually is that there's diabetes occurring, that there's hyperlipidemia that's going along with it, and that these individuals also have hypertension occurring along with it, which correlates to metabolic syndrome. Male gender, who would have thought? Okay, so of these, look at smoking. What does smoking do that makes it a risk factor? What does it do to the vasculature?
It's constrictive.
Yes,
Yeah.
exactly. What does hypertension do?
Adds more pressure to
Pressure and can damage those small vessels.
Yep. So let's say I have hypertension and I'm a smoker. Did I just double the constriction that's possibly occurring in my arterial system?
Yes.
Yes, you are. Did I increase the impedance potentially of bringing blood back up to my heart? Yes, absolutely. Okay, so frequency. Here are your two top things that occur. Type 2 diabetics and hypertension are your two most prominent causes of end-stage renal disease. Both of these are also the causes of stage 1 and stage 2 renal disease. If people do not manage these, they will develop renal disease. It is going to happen. I cannot tell you the date, I can't tell you the time, but I can tell you that it will happen. If they have both of them, it'll happen more rapidly than if they just had one of them. As you look at this particular slide, can you guys see how I could formulate a test question off of this? Like identify the disease processes that are most prevalently associated with the development of end-stage kidney disease. That would be a multiple question where you'd have to choose more than one answer. You will see something like that on your test. Okay, so you guys have your answer right here. Here are your two. It's not type 1, it's these guys. Type 1s are in the doctor's office being managed on their insulins. Their inflammatory processes are usually pretty minimal because of the strong control that we have of their sugars. Type 2s, a lot of times they don't come back, or they haven't. It's like, I'll just do diet and exercise, and they're gone for a year. And they come back and they're like out of whack. They've got a hemoglobin A1C of 7. Type 1s will wind up in the hospital if they don't control their sugars. Type 2s, typically not. This gives you a prognosis of understanding if you have chronic kidney disease by GFR and albumin, what's going to really happen. So prognosis of kidney disease by GFR. So depending upon what my GFR is and my albumin, this particular slide is saying, okay, using my GFR and looking at albumin, what is the potential for me to actually develop chronic kidney disease? That's what it's saying. So the green means no potential at all. Yellow means that there's a slight risk. Orange means you're more at risk, and red means you are at risk, you are going to get it. Okay, so let's over here on G3A, mild to moderately decreased GFR, so the 45 to 53. Okay, albumin. So if it's normal, it's a mild increase. And if it's less than 30 milligrams or less than 3 milligrams, I'm still in the caution area. And then you can see how it just progresses. So the lower your GFR gets and the higher your albuminuria gets, the greater is the probability for the development of chronic kidney disease. Does that make sense? Okay, I hope so. Let me know if it doesn't. So what are the complications that occur with chronic kidney disease? So you've got a patient who's got chronic kidney disease and they see a nephrologist, but you see them for everything else. So what do you have to be watching for? You have to be monitoring their cardiovascular system, watching for hypertension, checking to make sure that if they have dyslipidemia, that you have them on some type of cholesterol-lowering medication. Okay? You need to be assessing your patient's medication dosing and making sure that the dosing that you have for these medications is one that will allow for them to have renal clearance of the medication so they do not become drug toxic. So that may mean that some medications, the dosing may need to be changed so that the body is able to excrete it more easily, and you don't have buildups of drug toxicity, which could then lead the patient into more complex system problems along the line. You're going to need to make sure that you're checking for a CBC and you're checking for the anemias. They can develop bone demineralization, so they can develop osteopenia and osteoporosis. They can develop mineral disorders. So for these particular patients, you are going to possibly want to do a DEXA scan on them so that you're checking to make sure that they haven't developed these osteoporotic problems. If you're seeing your patient have hypercalcemia, they're breaking down their bone. And so I would be looking to see what is their risk for a fracture. They have a tendency to have malnutrition. So you want to make sure of how they're doing on their diet. Do they understand about watching that protein that comes into their diet? And if you're sensing malnutrition and you're seeing that through their serum albumin levels being low, then I refer them over to a dietitian for dietary management. These individuals can also develop neuropathies, and we typically see the neuropathies in their feet and in their hands, just like in the diabetic. They're more at risk for infections to occur. There is an immune system component that comes along with this. Because they're not able to properly begin to excrete the byproducts of the human body, these can build up and they can cause cognitive impairment because these products will cross over the blood-brain barrier and cause inflammation of the cerebral tissue. This particular slide is just giving you another synopsis and another view of who's most at risk. We all know it's people who are older. Okay, what could affect death? So who may have chronic kidney disease could die? People who have GFRs under 15 are more prevalently probably going to die. People who have cardiovascular disease and their relationship to their GFR, and people who are hospitalized and their association with GFR. So age and GFR, who's possibly going to be hospitalized. People who have significant chronic kidney disease wind up having a lot of other comorbid medical problems develop, and one of those is cardiovascular problems, usually with hypertension, and they develop edema. So here's a question. Common causes of chronic kidney disease include all of the following except
Hypotension would be AKI instead of CKD.
Oh, I didn't hear that last one. What was that?
I said hypotension would be AKI, not CKD.
That is correct. You go, guys, and you are correct. Yeah. Now, if the hypotension went unchecked, it would lead into the acute kidney, kill off the nephron, and that would turn into chronic. So what you just did in your clinical reasoning of understanding that hypotension initially has to cause acute before it can cause chronic, that is a key piece to remember. Key piece to remember. Moving forward, now we're going to get into the primary care. And I've got some really nice tables that Nicole gave me that I'm going to share with you. This is an amazing little table to help you understand what to do. So how do you screen? It tells you what to screen. If you find something, what do you do with it? And it literally walks you through every single process. This is a really, really nice tool for you guys to have, because it walks you through not just diagnostically what you're supposed to do, but if you find that the person is developing, how are you supposed to work with this? And it tells you, okay, if their BP is like 130/80 and their ACR is above 300, here are some things that you should do. Okay. You can try an ACE or an ARB, but it tells you when to try that. You could try a diuretic, and it talks to you about putting that person on a sodium-restricted diet. So it really walks you through the entire process. It also tells you when you should refer the person to nephrology. So really, really great tool for you guys to help you understand in primary care, okay, what should I do and how should I do it? How should I monitor them and when should I refer? It gives you all of that in this one slide. So who should be screened? Well, you already have figured that out. Anybody who's getting older people who have hypertension, diabetics on a yearly basis, if not more frequently, especially if they have an acute injury to the kidney occur and it recovers, but it doesn't recover all the way back up to the GFR of 60, you need to keep on that and make sure that that kidney does recover. If not, they're going to go from acute kidney injury actually into chronic kidney disease. And then you're going to have to review their meds and make sure their meds are renally dosed. So how do you screen? You can do a spot urine, and you can do that serum creatinine to estimate GFR. You can do the GFR, but a CMP is going to give you BUN and creatinine, and it's going to give you a GFR. So if you decide, you know what, I think this person has chronic kidney disease, now what do you have to do? Well, now you have to decide what stage it potentially is. You can do that 24-hour urine collection and do the 24-hour creatinine and the 24-hour proteinuria collection, and that will tell you where your person is. If you get a GFR under 30 or an ACR above 300, refer them to nephrology. Don't try to manage this. They will get them managed and refer them back into you for all their other medical care. They typically will start seeing the nephrologist on a regular basis, with nephrology handling the kidney component of their health. In the person's medical history, you want to make sure that you identify, has this person taken nonsteroidals in the past? If they have, how much are they taking? How long have they taken them? What is the reason that they are taking them? Especially if you're seeing a decrease in the person's GFR. Is this person hypertensive? Are they on antihypertensive medications? If they are, what medications are they on? Is the person taking diuretics? What type of diuretic? How old is this person? And are they taking the diuretic because of another compounding medical problem? So you have to take into context these particular elements. When a person actually develops chronic kidney disease, they usually have something occur before that. So we usually have some type of an acute kidney injury occur. If it is a diabetic patient or a hypertensive patient and it's evolved over time and they haven't seen a doctor over a long period of time, the time frame when we could actually see the acute injury occurring can be missed. So they may come into the clinic already in chronic kidney failure or chronic kidney disease state, because the window of opportunity when they're acutely evolving is not able to be seen anymore. So here are their symptoms. Nausea, vomiting, that metallic taste. This metallic taste is a big signal. Edema of the lower extremities. It's usually pitting edema. It's greater usually than 1. Shortness of breath. They're very tired, and itchy skin is a biggie. And remember that itchy skin, that is actually going to be the metabolites of the human body. Instead of them being excreted out, are being placed back into the subcutaneous tissue. And you're actually feeling the subcutaneous tissue's reaction to those with a histamine response. And then the foamy urine is indicating that there is protein being excreted. So if I gave you a test question, and on that test question I said, a patient, a 48-year-old male, presents to clinic with the complaints of nausea, vomiting, and itchy skin. Of the following, I have to add more to that. You wouldn't be able to figure out from that. But if I guess that the patient had foamy urine, is concerned about foamy urine, would you be able to automatically start keying in on nothing else gives foamy urine but proteinuria? Would you be able to do that?
Yes.
Okay.
Yes.
This foamy urine thing, it's going to show up on your test, I'll guarantee it. So if you see foamy urine anywhere, start thinking, okay, Kim said proteinuria, proteinuria. What does proteinuria mean? that there's something happening with the kidney, okay? So recognizing it, testing and detection. So another tool just to use to help you guys figure out, okay, what am I supposed to do, okay? So testing, you're going to do your serum creatinine, get your GFRs, do a urine albumin, detection. It just moves on down the line, okay? But I'm really looking for you guys to be able to look at lab values and determine from lab values. So a physical exam, you want that blood pressure, and you want to look for volume overload because they're not able to get rid of fluid. So your first thing you're going to do is you're going to look at the lower extremities. Listen to the lungs. You're going to listen for any bronchi that could be present. There could be an effusion, so you guys can do the agophomy and the tactile phragmatus. And then listen to the heart. There could be rubs or murmurs present. The skin typically has it's pale, but it's not the pale like we know when somebody has a fever or somebody is anemic. It's a different kind of pallor, and it's almost a pallor with a little bit of a yellow underhue to it. Your lab test for diagnosing chronic kidney disease, of course, you're going to get the CMP. Your CMP is going to give you your serum creatinine, your electrolytes. You probably have to add the phosphate to it. Some of them don't come with it, so I would check what your institution uses. You'll automatically get an albumin. You'll need to order a CBC because you're looking for anemia. You want to check the parathyroid hormones. You want to get a urine for protein. I would hold off on doing your HIV testing and your hepatitis testing and your SPEP and your UPEP testing. Hold off on that right now. You can get that after you get some of the other stuff back. If the person is a diabetic, you need to make sure you have a current hemoglobin A1C. And then you want to send them for ultrasound of their kidneys to see if there's something going on that you're able to see. Sometimes there's tumors that are present. Sometimes there's cysts that are present that are actually causing the CKD to occur. You find them, they get corrected, and the CKD resolves. So with proteinuria, this is just another diagnostic tool to use on how do you evaluate out if you've got proteinuria, what do you do next? So it walks you through the process. The management of chronic kidney disease, again, this is the risk and the prognosis based upon what we had before. So if you're in the green and your GFR is good, we're all in a monitor phase. But as you start moving down with that GFR, when you start getting down to a GFR in the 30s and the 40s, and we're on a monitor 2, we have more we need to be doing. And we need to be more diligent, bringing them in, watching their meds. So instead of them coming in on a yearly basis, we may need to have them come in twice a year for assessment. People who are sitting with that GFR in the 30s and the 40s, they will evolve out and they will wind up very quickly needing to be referred over to nephrology. Here's your question. Which of the following is most likely to initiate dialysis due to CKD? So you're looking at those GFRs. Look at the age of the person.
The GFR less than 30 in the 64-year-old woman.
So you're choosing B.
Yep.
Who else is choosing B?
Yeah, because it's less than 30.
And diabetes.
And diabetes.
Yeah, and diabetes, yeah.
Yeah. And diabetes.
Good pickup, guys. Now, before I show you the answer, let's go between A and B. So just looking at age, who's more at risk?
B.
64.
64 is more at risk. Yep. Now, one's a man, one's a woman. Okay, so could or could not have a thing here. Hypertension, we know could be a bad thing. And diabetes, we know could be a bad thing, right? So would these two be like a washout?
No, because of the GFR.
Yeah,
Right.
treat hypertension.
Yep. Your GFR is your key here. We're in trouble. This person, she's going to get uremia and she's going to die.
Mm-hmm.
So good job. And your answer is correct. All right. So actually looking at, I've got notes at the bottom of the slides for you guys to help explain why versus another. This one here is just probably normal from age. This one here is probably pre-renal. Okay. This one here is our answer. And the 46-year-old, they probably are going to need to be more closely monitored, but they're a stage 3A. This one here definitely is in dialysis stage. So again, the lower portion of the slide I showed you before. So how do we actually slow the progression? So how would a nephrologist slow the progression? Or if you caught them early, how would you slow that progression? Well, we can give them our ACE inhibitors or our ARBs, and we can really work to have this person try to become as healthy as we possibly can. So getting them to go ahead and lose weight, getting their diabetes under control, if they're hypertensive, hopefully one of these meds would help. Making sure that their diet is appropriate, that they're not having too much protein or too much salt. If they are smoking, work with them for smoking cessation. We can work with them and give them some vitamin D. This is going to help offset some of the calcium loss that's going to occur in their bones. So these are some of the things we can do to help them a little bit more homeopathically, and here's how we can do things more with their meds. So in primary care, we want to make sure we've got their blood pressure controlled. We want to make sure we have their diabetes managed and controlled. If proteinuria is occurring, we need to treat the proteinuria. We're going to get there in just a few minutes. If this person has hyperlipidemia, we want to make sure that we get their cholesterol levels lowered. We want to prevent them from developing clots on top of plaque, which can happen not just in the heart, but in the renal artery as well. So a little ASA, as long as it's not contraindicated for that patient. Just a baby aspirin a day is all you need. So for blood pressure goal, you guys, I believe, had blood pressure goals in the past, but now we're looking at blood pressure goals with respect to the patient that is a chronic disease patient. And with this, we really want to get them down low. So we want that person to be under 130/80. The SPRINT trial is saying people who have chronic renal disease, we need to get them into the 120/70 range. That's controversial. We definitely need them, though, diastolically under 130, systolically under 130, diastolically under 80. So the meds, we talked about the ACEs, ARBs. ARBs, we have to be a little bit careful with the ARBs. We're going to talk about that one in just a second. So control their sodium, and they could potentially be on a thiazide. Loop diuretics we reserve for people who have a greater comorbidities occurring, because once we start them on loop diuretics, it's just a progression upwards, and we can't go back into the thiazide range usually. Just a picture of your renin-angiotensin system in case you forgot. For the treatment of the proteinuria, for this one here, we are either going to use an ACE or an ARB, not both. And most people have a tendency to go towards that ACE inhibitor instead of the ARB. Insurance companies sometimes will balk at paying for an ARB. They want them on an ACE first, fail on the ACE, then go to the ARB for blood pressure management. Again, if that person develops a cough, we have to take them off and try to find a different product to use instead. Sometimes we'll go into working with our calcium channel blockers, but we know that those are going to cause heart rate changes. We can work with our beta blockers, but we would have to go to a selective beta blocker. But we would have to be careful what we do, looking at, okay, if I give this category of drug, how is it going to affect other systems, and is it going to be workable? So here's a question. ACE inhibitors can limit the progression of some forms of renal disease by, how do they work? So do we want to increase pressure or decrease pressure?
Decrease.
So which one of these answers says decrease pressure?
B.
B.
There you go. That was a hard question. Would you guys agree?
Yes.
Yes.
Okay. So helping you think through hard questions when you're unsure of the answer, we're dealing with renal disease. It says it. And it's talking about ACE inhibitors. And we know with renal disease and ACE inhibitors, ACE are usually given to reduce a pressure of some sort. So which one of these is talking about reducing pressure? And that's how you can get to your answer. So you kind of have to take the question apart. Okay. The use of which of the following medications can precipitate acute renal failure in patients with bilateral renal artery stenosis?
That's the ARB.
Yes. That is the ARB. You are correct. And that one was on boards. So just some more slides that are just giving you comorbid states. I'm running over on my time, and I know you guys have things to do. Sorry about that. Cardiovascular disease, risk factors versus non-traditional risk factors. I think we've covered that. This is just going into explaining the relationship of cardiovascular disease and chronic kidney disease. And when you look at these, this makes sense on why they'd be there. Your biggest one is going to be your atherosclerosis. That's your big one right there. So when do you refer for specialty care? The GFR under 30, ACR above 300, a 25% decrease in their GFR from the time before. If you find out they've got hyperparathyroidism, persistent hyperkalemia that you correct and it doesn't correct, it keeps returning, that's telling you that something's off. Metabolic acidosis that you can't get corrected. Reoccurrent kidney stones that keep coming back and occluding. Now, I want to talk just a second about kidney stones. When people get reoccurrent kidney stones, you can give the person hydrochlorothiazide or hydrochlorothiazide and triamterene, known as Maxide. And this helps to keep the kidneys flushed and to disallow the accumulation of minerals within the kidney to cause a kidney stone. So one of the treatments of kidney stones is actually using hydrochlorothiazide and triamterene, in case you guys didn't know that already. Okay. Complications that can occur. So these are some nutritional things. We already know about obesity and overweight. It increases your risk for cardiovascular and for CKD. We want to do a low sodium diet to control that blood pressure, do a low protein diet, watch potassium. They may require a calcium supplement. If you're going to prescribe a calcium supplement for your patient, you need to prescribe a vitamin D along with it. A lot of our supplements come calcium and vitamin D together. They're more pricey than doing it separately. And it would be vitamin D3 is what the person would need to take, and at least 2,000 to 5,000 units per day. This is how we develop our osteoporotic occurrences in the person with chronic kidney disease and the decalcification that occurs within the bone, and why you see hypercalcemia occur in the chronic kidney disease patient. Some of the bone disorders you can get, fractures are your number one thing. The others can happen, but the fractures are the number one thing that we see. Other bone pieces, you can start seeing vascular calcifications because of the laydown of calcium that begins occurring outside of the kidney because of the decalcification that occurs. Anemia is one of the other things that we typically see in our patients with chronic kidney disease. And the reason is because we have an insufficient production of erythropoietin. There's usually an iron deficiency. Your patients that have chronic kidney disease and they are on dialysis typically always have some mild form of anemia occurring, typically. Okay? So the standard symptoms of anemia. We're going to go over anemia next week, so I'm not going to get too big into the anemia. What I need you to know for this week is that anemia is one of the complications that can occur with chronic kidney disease. That's what I need you to know. And I need you to be able to look at a lab value and be able to identify that anemia is present from a hemoglobin and hematocrit perspective. Okay, because I said that, here's your question. Okay, which of the following would you expect in a person who's 75 with anemia and chronic kidney disease? Which one would you expect to see? This is a hard question.
Would the MCV be low? Why would it be low?
Well, it's the mean corpuscular volume. Go ahead.
So it'd be microcytic
Uh-huh.
anemia.
So your answer is actually going to be C. So A represents a microcytic anemia because the MCV is 69. B is a macrocytic because the MCV is above. Okay. C, this is actually, it's a normocytic, normochromic.
Mm-hmm.
Okay. They're just low in their hemoglobin. And for D, they have a high retic count, which is probably going to be related to some kind of immunoproblem. I'm not going to give you this kind of question on this test because you haven't had the anemia lecture yet, so you're not going to see this on this exam. But you may see it on the one for anemia, but you're not going to see it on this one, okay?
So with chronic kidney disease, it's normocytic. It's
Yep.
not microcytic or macrocytic.
Normocytic,
Normochromic.
normochromic,
Yep, just a low hemoglobin.
and normal
hematocrit.
reticulocytes. Okay.
Yeah. There you go. Good job. So nephrotic syndrome, this is when you have massive amounts of protein coming out of the kidney. Some of the things that you're going to see occur. So for this particular patient, patients with nephrocytic syndrome include all of the following except. What's your favorite answer?
Hypotension.
Yep, there's your favorite answer. That's it. Not going to happen. Not going to see it. They'll be hypertensive. The remaining slides, you guys, are about medications, and you can review them at your leisure. But Nicole really wanted you guys to be able to have good understanding of when people have chronic kidney disease, how do you change how you do things with medications? And so she has provided you with an entire plethora of what do you do with these meds to help you guys understand what to do. So you guys can thank Nicole for that, okay? So that ends what I'm going to talk to you about today with this. There's a couple of questions at the end that you guys can go over on your own. I'm way over my time with you, and I don't want to take up more of your time. Before I say goodbye to you, do you have any questions? All right. I'm almost done finishing your PBLs that you turned in this week related to our wonderful man with the interesting presentation that could possibly be prostatitis. And I'll be having those up hopefully like in the next 2.5 hours for you guys to look at. If you have questions as you go through the week, please don't hesitate. Please make sure that you reach out to me and let me know how I can help you answer questions. And if anything isn't making sense, please make sure you reach out. I've already been through next week. All links are working. Everything is up and A-okay. Anemias are fun. And I'm hoping that you guys can really get into the anemias. We see a lot more than we see. And then you think you see in primary care. So thanks you guys for being here today. I will be up online with you later in the week again. I'm going to post another podcast kind of a thing for you, letting people know to please watch the video from today because some of the test questions for the renal exam are inside this video. So you guys have seen some of the test questions. So good for you. All right. Any questions? Okay, guys. Bye. Have a
Thank
good
you
afternoon.
so much.
Bye. Thank you very
Bye.
much.
Take care.